The disclosures for guests on this podcast can be found in the show notes.
Hello, and welcome to JCO at ASCO 2026, our series where we cover some of the top JCO papers published simultaneously with their abstract presentation at this year's meeting in Chicago. I'm your host, Dr. Jake New, JCO Editorial Fellow, and I'm joined with Dr. Andrea Necchi, JCO Associate Editor, to discuss the Journal of Clinical Oncology article and ASCO Annual Meeting Abstract Presentation, Addition of Intravesical Recombinant BCG to Perioperative Chemo-Immunotherapy in Muscle-Invasive Bladder Cancer, Primary Analysis of the Single-Arm Phase 2 Trial, SAKK 0619 by Kathmos et al. So, Dr. Necchi, let's start with the relevance of this article. Can you explain this to our listeners?
It's an absolute pleasure to be here today discussing this simultaneous publication because it's a very interesting study. It's a relatively small phase 2 study in patients with muscle-invasive urothelial bladder cancer with clinical stage T2, T4, and 01, M0 with pure urothelial carcinoma histology. Patients that are classically fit for a standard neoadjuvant cisplatin-based chemotherapy. And these patients in this single-arm, single-group study received a combination of an immune checkpoint inhibitor, atezolizumab, and standard chemotherapy with gemcitabine and cisplatin, which is the standard backbone chemotherapy for this patient population, in combination with a recombinant intravesical BCG therapy. The neoadjuvant part was followed by, as a standard of care, by radical cystectomy, with the possibility of adding a tail of adjuvant atezolizumab in patients who showed or revealed the pathological high-risk features at the time of radical cystectomy. So the study is an investigator-initiated study. So it's important to say it's a strong effort. Every one of us that is used to run independent academic studies in this clinical setting, multidisciplinary settings, know very well how difficult they could be in concluding and in successfully publishing them with the primary results. It was a cooperative group study, Swiss study, made by Swiss oncologists and urologists in a multi-center fashion. The study enrolled 50 patients, then 47 were available for a safety, and 40 patients underwent radical cystectomy, and so were available per protocol definition for the primary endpoint, which was the pathological complete response rate, so absence of any viable cancer at the time of radical cystectomy. Secondary endpoints were pathological downstaging to non-muscle invasive disease, and other classical endpoints for neoadjuvant studies like event-free survival, overall survival, and of course, safety. Safety, starting from the latter point, was quite good. The authors used a recombinant version of the BCG vaccine, so a relatively new way, a new version, new strain for the BCG treatment, which is a bit different from the classical strain of BCG that is used for non-muscle invasive disease. The BCG administration were made 3 times, starting from day 1 and then biweekly for 3 times. And then Chemo-Immunotherapy was performed and was administered for 4 cycles every 3 weeks preceding radical cystectomy. The primary endpoint for a complete response rate was reported in a challenging patient population with a compelling rate of PCR of around 68%. 27 patients out of 40 patients achieved the PCR. A population of as high as 83% achieved the pathological downstaging. So numbers may look at the bit lower if we consider the intention to treat population of 47 patients at the denominator rather than 40 patients that actually underwent radical cystectomy. But as a matter of fact, these proportions are compelling. In a population in which chemo-immunotherapy studies have provided the PCR rates ranging from various studies from 30% to 40%. So it's actually an improvement. And the authors were able, despite the single-arm nature of the study, to perform a retrospective comparison with the results obtained with a similar study they published a few years ago with a combination of immune therapy and chemotherapy alone, so without the intravesical portion. And they showed that actually there was an improvement in the rates of responses seen as pathological complete response or pathological downstaging. The follow-up is relatively short, so event-free survival and overall survival are compelling, but we have to be cautious looking at this. Also, due to the single-arm nature of the study, there is anyway something to consider for the next follow-up of the study, the next updates from the study. So overall, the study provides for the first time, in my knowledge, results with the use of a combination of BCG therapy, intravesical therapy, and chemo-immunotherapy. This is something for sure to test further in larger studies, even though we have to consider the fact that the situation here and the standard of care is rapidly changing. And we have now a new standard of care, which is actually overcome the limitation of chemotherapy. So the new backbone, for standard therapy in a neoadjuvant setting today is enfortumab vedotin and pembrolizumab combination. So looking at the future, it is quite difficult to see what is actually the next right move.
And very well said. It's really encouraging to see that pathologic complete response rate. And I thought that analysis and comparing it to the prior study was quite robust in being able to compare one benchmark to the other. What a novel thing. You want to expand a little bit more about how we should think about BCG, what made this recombinant BCG unique, why this hasn't been done in the past, and more forward-looking, like you mentioned, how should we think about this in the future?
At the moment, at least, we have no strong argument to see or to think that recombinant BCG version of the therapy that is used in this study could be necessarily better than standard strain of BCG. The fact that BCG has never been tested in muscle-invasive disease, actually, it is because it was usually considered as a way of delivering an adjuvant therapy in patients with a radically resected, minimally infiltrating PT1 or PTA or CIS tumor. So the point that was that always felt by urologists, it was particularly related to the fact that the possibility to get a systemic disease control for intravesical therapy alone was felt to be problematic. And this is actually true. But today we may have drugs that may combine quite well, like immune checkpoint inhibitors. And these preliminary results are actually indicated that there could be an added effect, an additivity, or maybe somehow a synergistic effect of the combination therapy in this tumor. So for sure, something to consider. Is not quite relatively original in the concept of combining intravesical therapy and systemic therapy, because we do have in JCO, published a few months ago, for example, the results of Sunrise-4 study, which was a phase 2 study which tested combination of intravesical TAR-200. TAR-200 is an intravesical chemotherapy delivery, so in that case was chemotherapy intravesically, and combined with an immune checkpoint inhibitor given intravenously. And the same or similar results have been reported in Sunrise-4, so very high, very promising rate of PCR, not as high as in this case, but equally favorable in terms of path CR and path downstaging. So there is accumulating evidence that this could be a reliable strategy. And how about, for example, thinking about combining same intravesical therapy with newer systemic therapies, like, for example, EV-Pembro, that's changed the backbone for standard systemic therapy quite recently in this disease. So that could be an option, based on this study, I think, to consider the possibility as a next generation SAKK study for combination of BCG and EV-Pembro. The other point that is very important to me, and this is why the results of the study are compelling, is that when it comes to the consideration of regarding the possibility of skipping radical cystectomy, that is an ongoing debate, intense debate in patients who get a complete response, clinical complete response to neoadjuvant therapy. We see from earlier studies that we did, the SHORE-2 study or a RETAIN study or Matgalski study, that the vast majority of the relapses, they usually occur in this kind of strategy. So keeping the bladder intact while continuing immune therapy or while observing patients, making patients on observation alone, are represented by intravesical, high-grade, non-infiltrating relapses. This is a suggestion, an important suggestion that maybe the use of intravesical BCG could prevent this kind of relapses. So it is important also for making further consideration regarding the role in the next generation studies of radical surgery in this patient population.
It's very interesting, very thought-provoking of what comes next. Just for our listeners, is there anything that you take away from this study to implement today in clinical practice?
The shift to clinical practice is quite hard today, primarily due to the fact that I mentioned before that the backbone of systemic therapy has changed, actually. So Chemo-Immunotherapy, with the only exception of Niagara study, that is still a positive study. So durval gemcitabine is still a standard of care in the only standard of care, together with chemotherapy alone in the European Union. But actually, we know very well that EV-Pembro is the new standard de facto. The problematic point for this study is that relying on Chemo-Immunotherapy backbone may be problematic when translating the results tomorrow to everyday clinic. But it is for sure something to consider, as I said, because I'm quite sure that in the routine practice urology experience, there are much more cases of patients with muscle-invasive disease that somehow have received an intravesical therapy in routine practice. So it would be another interesting point. It would be to collect this information from a routine practice that I'm sure is existing in several countries. So again, it's a pretty nice and unique study, and maybe the first one of its kind, portending new opportunities for patients with regards in particular to the possibility of de-escalating the intensity of surgery and the intensity of adjuvant therapy.
Excellent. Well, amazing discussion. Any final takeaways you think our listeners need to hear?
The final takeaway is that we can definitely de-escalate therapy, the burden of systemic therapy that we can provide to the patients as compared to the recently reported EV-Pembro burden of systemic therapy or Chemo-Immunotherapy total burden of therapy, in particular in complete responders. And this study provides a first hint to the fact that by adding intravesical therapy, we had very limited amount of side effects, and we could reduce the number of patients that have to receive an adjuvant immunotherapy, an adjuvant systemic therapy. So the overall exposure of systemic therapy for these patients is limited by the use of an intravesical therapy.
Thank you, Dr. Necchi, for speaking about the JCO article, Addition of Intravesical Recombinant BCG to Perioperative Chemo-Immunotherapy in Muscle-Invasive Bladder Cancer, a primary analysis of the single-arm phase 2 SAKK 0619 study. JCO simultaneous publications presented at ASCO Annual Meeting 2026. Please take a moment to rate, review, and subscribe to all ASCO podcast shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.